Well, thank you, Dr. Davis, for all the effort you've done for this weekend, and I appreciate that all of you are kind of maybe a little bit exhausted after a lot of education and a lot of drilling and stuff, and it was fun being in the lab. I'm very grateful to our panelists, and this group here actually are all our visiting panelists, actually. So these are all our visiting faculty: Dr. Janjua from UBC, Dr. Levine from Miami, Dr. Suh from UCLA, and Dr. Vaughn from the California Science Centers. And I want to extend my thanks to you all coming. You know, I think it doesn't say enough to say thanks, because it's such a time away from your families and your lives, and to come here to commit yourself to teaching others is something extraordinary, so thank you. So there's ground rules for this session, and I want to make sure everyone's aware of the rules. Dr. Davis, in particular, you. Okay, so one, there will be 2 teams, but only 1 vote per team. And just by the randomness of how you sat down, that is how the teams are decided. So we have the Suh-Vaughn team and the Levine-Janjua team. California. Okay. Oh, yeah. Yes, California. That's good. Team. All right. Oh, I just realized that. Good. Okay. All right. Now, 1 point will be awarded for each team when you're able to guess what I'm thinking. So I will be describing my future science practice, and you will tell me if it's true or false. So imagine you're me, okay? All right? My wife says that's not really great, but yes, okay. Greg Davis will keep track of points, all right? And the winner will be declared at the end, okay? And rudeness and interruptions are encouraged. There actually can be extra points awarded for interrupting others. Let's see how that goes, okay? Now, the first one is, I will routinely have a saline warmer set up for all my endoscopic sinus cases. Yeah, true from these guys over there? False. True or false? False? You guys have to decide as a team. Yeah.
False. I can see why one does it. I don't think.
Yeah, he's too lazy to do it. I mean, he's like, I'm going to wait for room turnover, to warm up, for the nurse to plug it in.
Yes.
I'm not waiting for that.
Yeah. You're going to say, so Dr. Vaughn, do you routinely use a saline warmer for your cases?
Never seen one.
No, Dr.
I use it for other things, but not
Every single case. And I would say it's just because it's so easy. We talk about all the things we do pharmacologically, therapeutically, injections, packing 1 in 1,000. Warm saline irrigation is easy.
Dr. Oh, you have to use a mic.
Point for both of you for not using the microphone.
Oh, yeah. Okay, so let's go back to why Dr. Janjua, why are you saying I should use it? Why are you saying I will be using it?
Oh, why? Yeah. Because I think that it's something that is a limited therapeutic intervention, which doesn't cost a lot, but actually has a beneficial effect on your ability to see. And I told you, see better, do a better job.
See better, do better. Dr. Vaughn, you disagree?
I disagree, because the head of bed elevation is enough. It does cost to use a warmer. It means you have to use the endoscrub, means you've got to have somebody spend time finding the machine. And if I bring the head of bed up 30 degrees, I'm off and running.
Well, I was thinking I will just have the pan of the warmer in there with the saline, and then have just to irrigate intermittently. Is that what you were thinking? Yeah.
Yeah, and I think my thought was do all of them. Why would I stop at doing one? Why is one good, but 4 of them, topical 1 in 1,000 injection?
We just don't need it.
Yeah,
exactly. We're so good in California.
So in this case, we have a. By the way, guys,
he's doing pediatric patients. Pediatric patients get cold.
That's why God created warming blankets.
All right, so this is great. There was almost a point for rudeness there. Thank you, Dr. Vaughn. Almost, not quite. So we're going to get 1 point because it's true. I will be using saline routinely, and I have not used it routinely, but I will start doing that.
Why warm? You would think cold would have more of a.
Why is warm better? Has there been a randomized control trial looking at that? Oh, Dr. Davis, yes.
Yes, there has. British Columbia. You want to talk about a comment study?
Yeah, from UBC, one of my colleagues did the warm saline irrigation trial, and it had just better intraoperative Bozart scores and supposedly blood loss. I'm not sure I buy that piece, but the visualization I think is better. It's that blood staining effect and then the soaking up of light. The red tends to soak up the light. Jeff operates without blood, so he doesn't need it, but the rest of us, it's going to help.
I do rinse quite a bit, so if there's any inflammatory garbage inside of the sinuses, like fungus or allergic mucin, I tend to feel that unless you get that stuff out, it just keeps on oozing. But as soon as you do a lot of rinsing, it makes it better. I just my neurosurgeons like the warm saline bath. I just don't.
Okay, we're going to move on. It's good that we have these very simple questions going really quickly. Okay,
What's the temperature on the warmer?
Temperature on the warmer.
Yeah, I keep mine really hot because I think it works even better. So we're talking like 30, no, actually 40 something, 44. I know that seems a bit
Celsius.
crazy.
Celsius, yes.
Sorry,
Celsius, yeah. So for you Americans out there, that's like 200.
The neurosurgeons
okay?
don't like that. They keep it at like 37. They want it at body temperature.
Yeah.
I keep mine really hot. The other reason is that we've got a super cheap, simple spigot flush thing where we take a stopcock that comes in like an IV thing, put the IV tubing on it, put it onto a suction, then you can use, and then put it onto whatever you want, an olive. You can use it as a flusher, so when you had that tenacious eosinophilic mucin, you put in your olive inside, turn the stopcock one way, it flushes, and then the nurse spins the the stopcock back,
right.
and it sucks.
Okay.
And so it's just fast, easy way to keep flushing
There
crap
might
out.
be a negative point for rambling here, so we're going to move on.
Hey, Sanjay,
Okay.
I just got to answer because that was a good question. 120 degrees for us Americans, and
Okay.
it's 39 degrees Celsius in that stuff.
Okay, next statement. I will routinely make a mental checklist of CT scan sinus anatomy prior to surgery. True or false? What do we think?
True for both of us.
True. Dr. Levine, you want to comment on that?
True,
Why?
because I trained here.
I think you're this. I was inspired a little bit by the formality of the checklist you put in your presentation, and I actually took a picture of it because I think that was so well done, and I think I'm going to try and promote that with our own learners that it actually is effective. And I do it informally, but I think having a formal checklist may be even stronger. So I thank you for that. So the answer to that is
Make
true.
them email it to you ahead of time.
Okay, great.
And then I would say that Winston's idea of a little cue card when you're doing that, trying to think about what the danger areas are, split the cue card in half, left and right, and say, orbital dehiscence on that left or something. And if you tape that to the thing, that's a great way to say, I needed to know 3 things about this case. This is the only 3 things. Everything else, obviously, I'm hoping to remember. These ones I need to know.
Okay, yes. How much have you drank? That's okay.
I might take that away.
All right. The next time I have a complication, I will not tell a patient that I'm sorry because it increases my risk of litigation.
False.
What do you think? False?
False.
Dr. Vaughn, what do you think?
False.
Why?
I'm sorry doesn't increase your risk. It just tells you that your mother brought you up well and your dad told you to say you're sorry.
And I think you made that point, and I thought I really appreciate that in your talk, because I do routinely say, I'm sorry. Yeah. And what I like to say is actually, I'm sorry you're going through this. And that's the exact phrase I use. So it's not my commitment to saying, I'm sorry I did something wrong, but I actually am. I feel sorry that you're going through this. And I got trained by a mentor who said the same thing to me, and I'll pass this on to you, is that when I have a really bad complication and it hurts, it's really hard to see these patients, right? Because you're seeing your worst outcomes right in front of your eyes. These are the patients you need to see the most frequently. So I see them, I say, I'm sorry you're going through this, and when can I see you again? Would you like to see me next week, the week after that? And whatever they say is my cadence of how often I'll see them. Because Dr. Vaughn knows that communication is a key ingredient to effective management of complications.
It also helps the surgeon. We internalize a lot when we screw up, and we hold those feelings inside. And when a patient says, I still love you, you're still my doctor, it releases that sense of like you're an asshole, and you'll sleep better and you'll feel better, and the bond between the patient and the doctor improves. So it's totally okay to say you're sorry, but it's also therapeutic for the physician and their team around them, the medical assistants, the doctors, the family, to feel like, okay, apology accepted, let's move on, let's get this going in the right direction.
I just had a little warm and fuzzy feeling. You get a bonus point for that. That was how good that was, okay? So one more. Dr. Davis, an extra point for the Vaughn team, okay? All right, tally. Okay, so I will say, so it's false. I will say I'm sorry. Okay, I will routinely, specifically discuss CSF leak and medial rectus injury as part of my informed consent. I will mention both of those complications. True or false?
True.
True.
Yeah, that's true. It's going to freak the parents out.
Sanjay's warm and fuzzy. He doesn't freak out the parents.
Yeah.
I I think it's false. I don't think he wants to freak all the parents out.
Correct. It's a false. So I'm going to go with my routine, and I wanted to talk about this because you called this out. My routine is I discuss orbital injury and brain injury as a routine, as a complication related to endoscopic sinus surgery. And this is a known documented problem. But I do not go into specifically CSF leak, and I do not specifically discuss medial rectus injury. Am I performing malpractice not having discussed those two specific arenas, or does brain orbit cover that?
They do.
They do?
I don't think you have to tell somebody, I'm going to crash the car and break your kneecaps off. You just say there's a chance that we may have an accident.
Interesting to think about.
Microphone. You're going to get negative in a second.
The interesting to think about.
You got negative? Already negative, okay. And you're rambling, watch out.
What I was interested in is why wouldn't they ask you, specifically in that pediatric, what I have them most often ask me, what does that mean, my injury to my orbit or injury to my brain? Because it's not really your brain, really. It's the casing around it that's going to leak. I wondered that they wouldn't ask you when you say that.
What I say is that I'm working between the eyes and below the brain. And so when we work near those areas, there's a risk to injury to the orbit and brain. That's actually the verbatim I use. And so far, it's been effective for me. But I think it's like, I don't know if I want to get into a CSF leak. How many people know what CSF is? How many people know what medial rectus is, right? So I think that's why I use the broader sort of common English language.
Yeah, I wouldn't say the medical term. I would say, there's fluid around the brain, and sometimes we can get into that fluid and we need to do a repair. So I don't usually use, unless it's a physician who has clearly looked up all of the stuff, I don't ever use any of that terminology, but I still talk about a CSF leak, or I talk about an injury to the eye and the ability to move your eye or to, see out of your eye. I go through that type of detail.
Mm-hmm. Mm-hmm.
Yeah, I do too. I say double vision or loss of vision as the two potential things that could happen to your eye.
Okay.
Sanjay, do you say orbit injury? Because I would argue that a lot of people don't know what an orbit is. So talking about
the eye. Yeah.
blindness, double vision, that's a little bit more concrete. If you say medial rectus, they might think something way far away from the eye. If you say medial rectus, just me.
Eye socket.
Eye socket, yeah.
Yeah.
I do say I'm working between the eyes and below the brain. I don't know. Yeah, I think I like where you're going with this. Thank you. Bonus point for you.
Thank you. That's what I was shooting for.
Now I'm going to get, those were some easy ones, okay? Now, for patients with CRS with nasal polyposis, I will not test for eosinophilia because it doesn't change how I will treat them.
You're talking about like blood eosinophilia, tissue eosinophilia?
Tissue. Sorry, it should be tissue.
Pre-op, post-op?
Intra-op.
Intra-op. Like a frozen section?
It's like afterwards.
Afterwards, okay. You mean like?
No more. You're heading towards negative.
Okay.
I was going to ask some questions too, but I'm glad you're in the negative now.
I don't think he's going to test for eosinophilia. I mean, it's high power field. Most kids are not going to be on biologics. He's going to do his first surgery. So I'd say false. He's not going to routinely test.
I think a lot of times pathologists.
Now, this is like an intense discussion here. Enough. Somebody answered. Dr. Jinjua, what is it, true or false?
I don't know.
I will not test for it.
No, false. But I do think I'm going to encourage you guys to put your pathologist on the spot and ask for this, because I think this, and being in pediatrics, I'm not sure because there's not biologics for pediatric populations.
Dr. Vaughn, Dr. So, what do you guys think? False. Okay, you saw my answer, but that was good. Good idea. I think you guys have convinced me otherwise. That's one thing I'm taking away from this meeting, is that I have not been considering that as strongly in my differential diagnosis and management plan, and you guys have shown me that it's worth it. So I'm actually going to be investigating eosinophilia more carefully across the board, preoperative,
or just
intraoperative.
Start to learn. Like it'd be better for us to learn, even if you don't do anything with that information, to know that, hey, that's an eosinophilic person, and that person's not. That we're going to learn something about the disease process as we move forward.
It's cheaper than warm saline. You've got the pathologist paid for. You've got the microscope paid for. It's cheaper than warm saline.
It's better than just saying chronic sinusitis. That means nothing.
Yeah. Okay, so thank you all for that.
Eosinophilic count per high power view.
And I write 400 times so that they can't.
I talked to the pathologist, and now they just do it for me routinely.
Routinely, really? And so
I have a
what's your
good relationship. Communication is key.
So what do you ask them, Dr. Levine?
I called the head of head and neck pathology and said, we never ask for anything. This is what we want routinely on one specimen every sinus case. So they document it on every single sinus case for us, whether there's greater than 10 or less than 10 eosinophils per high-powered field.
Okay.
And it can help with the authorization for these biologics, even though our allergy colleagues say, when you send that pathology report and you circle eosinophils, and then you draw a line to one of the biologics, and you draw a line to prednisone. So it's like prednisone, biologics, circle it, send that to the insurance company.
The clearance for allergists, at least in Florida, to be able to get paid to go see an allergist and have your insurance company approve it, this has helped for that. So actually, it's a huge way for us to advocate for our patients to be able to go to allergy, which may be something that could help you.
Okay, let's go on the next one. I will routinely use long-term macrolides for symptomatic eosinophilic polyposis.
False.
False, from California, false.
False, California, and?
False.
Okay, you both get a point. Why is it, Dr. Jinju? Why is that false?
This is the neutrophilic population, and I'm not sure you're going to give long-term antibiotic therapy to your pediatric population, but the neutrophilic population, I think it could help, especially at the low dose. We don't have any data on pediatric dosing.
I have patients that have non-eosinophilic chronic polyposis with PCD, and we routinely use 3 times a week azithromycin for those patients. And I actually think, anecdotally, there's improvement. And the PCD group in my hospital specifically gives that to them for recurrent pneumonia. Sorry. Publish it. Publish that outcome. Okay, thank you.
It would be great. But the
Publish or perish. I will perish. Okay, yes, question.
Quick, so eosinophils, high-power field, how do you, the other one, neutrophil, how do you determine that?
Yeah, you can ask the same thing. We just don't have as much of the risk stratifier. So with the eosinophils, at least we know 10 or over is a cutoff. 55 and over per high-powered field puts you in a severe risk of recurrence of your polyps. So those two numbers, 10 and 55, help you do something.
Nothing to figure out who was in the neutrophil.
You can ask for neutrophils. If they say abundant neutrophilia, they just don't use, like, it doesn't help us because we don't have the kind of published data to say above this means more neutrophilia. But
One of the slides up there, I mean, the treatment was different. One of them gets,
macrolides,
macrolides, the other one doesn't.
steroids of some form. That's why it's so valuable to
Everybody's
know.
getting steroid nasal sprays. Well, it turns out fungal sinusitis, people shouldn't.
That's not totally
That
true.
was on a slide.
Invasive fungal systemic steroids, maybe. I think allergic fungal, they're very steroid responsive. Very steroid responsive.
I did see that area, the 4 columns, and I saw that, but maybe it just means like long-term or something. But yeah, usually routinely we give oral steroids in those patients to control things. And then
Minus 1 for not using the microphone.
Oh, God, you lost a point for not using microphone. Sorry, Dr. You go ahead. Say it again, though. Can you repeat what you just said?
No, I'm good.
You intimidated him. How was that?
Routinely, we'll give
-2.
steroids for the patients with allergic fungal sinusitis, but just not long-term oral steroids.
Okay, the next question is worth 3 points. Okay, it's worth 3 points. This is a big one. After watching a video, Greg Davis's video of mid-face collapse during inspiration, as a friend, I will kindly suggest to him that he consider mid-face rhytidectomy and/or blepharoplasty. True or false?
We think it's true because we like Greg, and there's nothing wrong with a smart, handsome, kind, caring physician who looks good on his telehealth conference calls.
I'm going to say it's false because Sanjay is a supportive individual and he wants to support Greg at any form that he arrives in.
The answer is false, not because I'm nice, because I would recommend batten grafts actually first. I think batten grafts is where he needs to go. He has this really bad alar collapse on inspiration. Dude, come see me. All right, next.
3 points, wow.
When I perform isolated revision frontal sinus surgery, I will most likely perform a draft 2A.
In Pete's, maybe they did the balloon first. That would be reasonable to do 2A.
California says false.
Okay, I'm going to say true. I'm going to say true.
False.
Oh,
So
what are you going to do?
I think you guys have convinced me that I need to really think about taking down that head of that and middle turbinate and getting better exposure along the septum. I liked what I saw. I'm not doing that. I'm going to start bringing that to draft 2B.
But if you're not actively doing that, then that means we won.
We're not actually. No, I will. When I perform the exercise, I will most likely perform a draft 2A. So the answer is draft 2B. I think you guys have convinced me to be or not to be. And I think it's, you guys, it looks effective. And I'm having trouble with some of my patients getting visualization in clinic of the frontal sinus. And I think that's going to give me better surveillance opportunity. Don't you? What do you guys think? Is surveillance better with a 2B or 2A?
Better. I mean, I think the hard part is trying to figure out what's the problem. If you have a polypoid middle turbinate that is diseased and never going to get better, take that out. If the problem is just the frontal, then I think that you can do a lot and leave the turbinate intact and take that space above, that window that takes off going from the front of the nose into it. So it's like drilling it out, but leaving the turbinate intact. You see when we drilled out the draft 3, you didn't actually have to take the turbinate. It's not about the turbinate, it's about figuring out where that disease is. Is it a frontal sinus problem? Is that an ethmoid problem? If it's an ethmoid problem because of a polypoid disease middle turbinate, take it out.
Okay.
Hey, so, I'm going to disagree. I get 5 points for this. By definition, when you do a 2B, you're taking out the floor of the frontal sinus. You're taking axilla over to floor and basically over to the septum. You're providing exposed bone. If you have just an isolated frontal and you can get a beautiful dissection with a 2A, you're done. So maybe I'm missing the question, but I say yes, true. If I have an isolated frontal sinus and I can get a beautiful, nice dissection like we learned in the lab today, I'm done at a 2A.
That's why I was saying that we use the term 2B to be the idea that makes it a better frontal. It doesn't. You can get a great frontal sinus opening with the turbinate intact by taking out all that bone at the agar mound that you don't need. And I think
do you think a 2B commits you to de-epithelializing the vertical lamella of the middle turbinate and the associated septum?
No. I think you can go with permutations.
If someone had a 2A the first time, and let's say I saw someone else's patient that had a grade 2A that was done, or it wasn't sufficient, and I go back to the OR, again, for me, I'm always thinking, what can I do differently? And if I maybe feel like the draft 2A wasn't good enough the first time, I would maybe do it again. But if it was done by someone
that's what I'm thinking too, is like most of my frontal sinus work I do, it's equivalent of a 2A. I don't just do a sinusotomy. I take it all the way from orbit to septum.
What
That's
about
just
the
the routine.
anterior wall? Are you taking out additional beak and anterior wall
Yeah,
when you're doing your 2A?
I like the Cobra. Love it, or the Hosemon.
Because if your initial 2A is taking out a lot of that stuff to the anterior wall of the anterior wall of the frontal, then yes, a 2B is probably where you should go. If you haven't taken it all out the first
And you
time.
should have known that I always do 2A first. That was what you should have been thinking.
we knew that.
Next, all right, we got to head towards the end here. I will not routinely remove a portion of the middle turbinate for my new comprehensive FES cases.
California says true.
True.
I think some of you presented I think Dr. Son, predictor, suggested that maybe there is a role of partial middle turbinectomy for routine full house cases. Can you comment on that?
Yeah, so that article in particular says that if you do need to do it, there's some significant benefit with olfaction and nasal endoscopy, but they had a caveat that they said we don't routinely recommend it. So they said do it if you need to and don't feel bad about it, and there's good reason to do it, but if you don't need to do it, then don't do it. I don't know. So now when I do it, I have to think of a reason that I'm doing it.
And by the way, I just want to apologize to the people. It's actually the answer is I will not true, but up here it says I will routinely, but it should say I will not routinely remove. So sorry if it's confusing here. So the answer is I will not routinely do that. Okay. Last couple. I will perform concurrent septoplasty with FES cases to improve access even without consent, as is considered part of the procedure.
If I know anything about medical legal environment in the States, I would say false.
We say false too.
False, yeah, false. I think that I'm going to ask you, would you do that? Would you have a septal spur in your way, you don't have consent, you think you can endoscopically address it, are you doing that without consent?
For me, the answer is I am, but it's not without consent because I put it on all the possible endoscopic septal reconstruction.
I have done that. I've done, I didn't see the septal spur. I did my preoperative evaluation. I get to surgery and I'm like, oh, darn it. It's there.
I have a huge advantage over you, is that guess who I can get modified consent from during the case?
Yeah, you can run outside. You can get it. And so there are times when you are in the best interest of the patient's outcome for the primary goal that you're in the operating room. You're going to increase the surgical dissection field for access. And it's an access. No, I'm going to bill for that septoplasty. No, I'm not going to bill for that septoplasty.
What do you
I will
think?
use that septal approach to improve the access.
What do you think about the surgical planning part of this? You know, like how important is this to have that on your consent as part of your planning, you know?
I mean, it is important because there are complications related to septoplasty. The same thing for inferior turbinate reduction. But there's also complications trying to leave something in your way that's making your surgery harder, and you're trying to jump over the wall, slide onto the bed, and sneak into the closet to put on your shoes.
Make your outcome worse.
And then you're like, oh.
Careful, Dr. Juju, you don't have a microphone again.
So, yeah.
Dr. Levine.
So I think that I also will usually put it on my consent. My residents know that I hate doing septoplasty, so when I do it, I really need to do it. But I think that it's kind of akin to saying, all right, I have a CT scan, it's 2 months old, and now I get in and my patient has disease in their ethmoids, but they weren't consented for doing the ethmoids. Am I going to leave pus sitting in the ethmoids? Of course not. I'd rather take out the disease that's in the ethmoids. So usually when I talk to the patients, I tell them, I'm planning to do these things. However, if I get in there and your disease is worse, I will look at these other areas. And I'm very, very specific about that in my pre-op discussion, and it's documented in my notes.
I have a similar question that's related, and I want to ask it. I don't write a different consent now for draft 3. I just consider that part of sinus surgery. If it's what we need to do to make those sinuses ventilate and aerate and healthy, I don't have a different consent that says modified endoscopic Lothrop procedure, draft 3 frontal sinusotomy. I just call that endoscopic sinus surgery to the extent that you need. Does anybody else do that? Do you specifically consent someone for a advanced frontal sinus aeration procedure?
Okay.
Kind of along the same lines, that question.
Yeah.
How specific are you for your consents in general? Does it say possible anterior, possible total ethmoidectomy? Does it just say?
Sure, yeah.
What?
The question is, how specific are you about detailing what portions of anatomy you're addressing during FES? If I can repeat, yeah.
I'm the worst person to ask, so that I'll just say mine quickly, is that mine says bilateral endoscopic sinus surgery, possible endoscopic septal reconstruction for all of it.
We do it by code. So, and I think most people in electronic medical records are by code. So I will put possible of anything that I think that I might do, and I will document my preoperative discussion pretty detailed. But I have to put it by code. So if I think that there's a possibility I'm going to do total ethmoidectomy, I will put in the total ethmoidectomy, and then I will underbill for comparatively for an anterior ethmoid, and I'll justify, but it's much harder here in the United States to get approved for a code that's more expensive the first time around. It's much easier to get the more expensive code and then downgrade than to get the lesser code, go from an anterior ethmoidectomy to doing a total ethmoid. So I don't know if other people experience that, but that's what we experience. So usually if I think I'm going to possibly do it, that's what I put in. And then if I don't need to do it, just like the septoplasty, I just don't bill for it.
Thank you.
To me, I'm wondering, because some systems, your consent to the patient may be different than your surgery schedule.
Mine has to be identical. So for me, I have no choice. What I'm going to put in for my codes is identical to my consent because it's electronic medical record. I don't know if you guys have different experiences.
Yeah,
Let's hear from
EMR
California, then I got the last one, and we got to wrap up. Yeah, go ahead.
I think that if you're reviewing your CT scans with your patients, then you've done the consent. So this is your frontal sinus, and I need to go in there. This is your sphenoid. It's clear. I don't have to go in there because there's no posterior ethmoid disease. So chance of blindness close to 0 because I'm not going into your sphenoid sinus. Going into your frontal sinus, other things can happen up there. So if you add the review of the CT scans, risk, benefits, options, and complications of medical and surgical management are explained to the patient. I personally reviewed the CT scan of the patient and their family prior to the surgical procedure. They understood plans for surgery, extent of surgery, complications, and outcomes related to such.
It makes for a great dot phrase on EPIC. Last comment about that, Dr. Anything else to add? Okay, last
Greg
one.
wants me to interject. So for all of my consents, I put a possible septoplasty on every single one, even if I'm not planning on doing the septum. And the only reason why is actually what you guys have already discussed. It's for access. And so I never know, like even if the septum is perfectly straight, I never know if there's a spot that I'm only going to be able to get to if I have a mobile septum. And so for every single case, the very first thing is possible septoplasty, and then all the other stuff that I'm going to do. And I tell the patient, you might need a septoplasty just so that I can safely get to where I need to get to.
Thank you, Dr. Anstead. Okay, last one. Okay. I will go home to my family tonight with a smile on my face, knowing that I got to hang out with colleagues who are trying to make patient sinus care better and safer.
True. You smile all the time.
The answer is, what do you think, California?
A little bit split decision here. I'll go with true. True.
True. It's true. I'm so...
Smile? Are you a smiler?
I woke up with a smile on my face knowing I was going to get to be here today with you all. This is like, it's fulfilled me. I've been saying this all day. I've missed doing this for a couple of years. Being with colleagues, talking about stuff that I love talking about. I have no one to talk about this stuff. And I got to do that today and watch some fantastic surgeons share some really amazing techniques. I'm really grateful to you guys coming all this way. I really am. And to all of you for participating, and Dr. Davis, thanks for hosting this. And I hope to see you guys again in the future. I think we have one more panel. Thanks, everybody.
Do you guys want to know who won?
Who won? Yeah, who won?
So Amy and I just had a discussion back here. We tallied up the points. We tallied up a lot of negatives up there. And at the end of the panel, Amy and I won.
That sounds like the voting was fair.
That's what we find united.
That was a hanging chat or something. All right, so the last panel, Ben, I don't know if you can throw up, it's only a one-slide thing. It doesn't really matter. This is really just to squeak out all our CME. And it's not really a panel. It's a quick discussion, and then we're going to get you out of here. It's something I like to call super pearls. And so every faculty member here, surprise, you have to think of one tidbit piece of advice that you want the participants to go home with. And the challenge is, I get to start, and you can't repeat what someone else has said. And I may get to say more than one thing too, because I'm the course director and I get to make the rules. And so if you want to change the rules, you just come up and talk to me and slip me a 20. So I also have this vision, and I've done this panel probably the last 4 or 5 years, I think, at the end of the day. And I have this hope one day of putting all these super pearls together, these little sound bites, and condensing it. And I bet that alone would be a super cool, like 30-minute talk. So the super pearl that I haven't ever talked about is the microdebrider. And I want you to start thinking of the microdebrider as a two-sided instrument. A good side, safe side, and a bad side, the danger side. And I bring this up because watching dozens and dozens of dozens of residents, fellows, participants at these courses, hundreds of participants of courses, and seeing so many people use the microdebrider in a top to bottom fashion instead of a side to side fashion. You're always protecting something with the safe side. You're always eating something with the danger side. Allowing yourself to think about a safe side. Let's say you're taking out the bulla. A lot of people, I was taught straight up and down, let everything get sucked in, but it cuts into the middle turbinate, cuts into the bulla. So you turn it so the safe side, the non-debrider side, is pushing into that middle turbinate. You're going to create more space. It's like an elevator. It's like a retractor. And now you have more space to take out the microdebrider, or take out the bulla. I never have, hardly ever, have the microdebrider in a straight up and down fashion. It's always side to side. That's my little super pearl. And then we're gonna go from front to back. So you better be thinking quick, because here it comes. We're just gonna do one, because I don't want people to overtalk each other. Thank you though, Ben. Ben, you've done an amazing job today. And yeah. Dr. Parikh, because you did such a fantastic panel, you're next, and then we'll just pass it on.
I think the super pearl for me is, as I mentioned earlier, was the CFTR modulators for cystic fibrosis are a game changer. I think anecdotally we're seeing such a reduction in doing sinus surgery in children, and I hope it really translates to really great health for our CF population. So if you have kids with CF in your practice, make sure you refer them to specialists who have the ability to give it to them. It's expensive though; it's about $300,000 a year for that therapy.
So this is a tricafta, and I tell you, I was doing cystic fibrosis cases 2-3 a month, maybe at the UW. Big menial maxillectomies, and I rarely do it now. And not because I'm in private practice, it's just because those adults now are doing fantastic. Arif.
I have one that I repeat, and that is think septum, do septum, and we've talked about it a lot, so I'll come up with another one because I just think from an access standpoint, from a mobility standpoint, for something that helps you achieve space inside the nose and your ability to instrument is good. The other one is the right shape. If you are doing sinus surgery right, you can visualize the anatomy of the cranial base and the orbits, and that gives every sinus a correct shape. And so for the posterior ethmoid complex, there's a box with a tail, and the same could be said about a sphenoid if you want to maximally aerate it. The frontal sinus is the shape of a half horseshoe if you're doing that right. That there's a shape when you maximally aerate the sinuses to the extent that you can and not hurt the turbinates, the brain, and the orbit.
That's a hard question. What's a super pearl? I'd say angle scopes. I mean, if you are not comfortable using a 30, 45, and 70 degree scope for cavities that are lateral from the septum, become comfortable with an angled scope, especially a 30 degree scope, not only in the office and the OR, but when you're done with your case, stop, take out the angled scope at the end of your case, and use an angled scope, 30, 70, to just look around at the end of the surgery. Can I give one more super pearl?
I was going to ask you, because I asked several ARS senior people, American Rhinologic Society's senior people, you may have two more for changing the rules, unless it's the same one that I'm taking.
I'll just have one more super pearl.
And I asked Winston to talk about, it was called the instrument challenge. What's your favorite instrument? So if you would comment on your answer for that too.
My favorite instrument.
Well, do you remember the instrument that you said?
I probably said an adult 90-degree forceps or my brain, yeah. So my favorite instrument is my brain because you can use that before surgery, during surgery, and it never breaks, hopefully. And it's really cheap. But my last super pearl is enjoy sinus surgery. So many of us get so anxious about it. I'm sorry I gave that medical legal talk because I know it tightened up a lot of sphincters. But sinus surgery is one of those things that you can really start off somebody with a lot of symptoms, a lot of screwed up anatomy, do a beautiful surgery, change their life dramatically, make them so much better, and really impact them. And what we're doing in endoscopic sinus surgery has really changed millions and millions of lives every single year across the world. And it's a fantastic procedure. You know, Dr. Stamberger isn't with us anymore. A super pearl is to be a wonderful sinus surgeon. Enjoy it. Don't get stressed out about it, and just do what we keep on doing.
My super pearl is actually what we talked about earlier from Karina's talk. So the medial inferior orbital floor, identify it early, and then use that to keep yourself safe. So you use that level to always keep yourself safe. So if you're ever lost or it's bleeding, you don't know where you are, go back to that medial inferior orbital floor and you identify it. As soon as you identify that natural os of the maxillary sinus, as soon as you identify that, you just also identified the medial inferior orbital floor. So you already have that right away as soon as you do the uncinectomy. And so once you have that, the rest of your surgery is going to go great because you're going to know how to keep yourself safe at that level.
So I have two, and they're connected. So one is to say that, you know, you're never going to get a better view than when you're in the OR, right? So if your view in the OR is a challenge, especially with whatever you're going to be using to view something in clinic, then you got to make it better because now you have an awake patient. You need to do a good debridement or whatever it is that you need to do in clinic. And if you can't do that, and you can't do it easily in the OR, then you're not going to be able to do it in clinic. And the second part of that is that I tell all of my patients repeatedly, many times, that surgery is part of their care. It is not a cure. It is a portion and a tool that we use. And their aftercare and their ability to do all the care with us and letting me do the care in clinic is equally as important as the surgery. And they need to understand that. And we need to understand that. And when we train people, they need to understand that. It's not about just getting to cut. I love to cut. I love to operate. But it's also about understanding how to do the care afterwards.
I think similar to what Dr. Vaughn said is we have to kind of think when we do sinus surgery, especially, all patients are different. The routines that we teach our residents of just doing a maxillary antrostomy, ethmoid, whatever, it can be the actual surgery that needs to be done for that particular patient depends on what's happening to that particular patient, their anatomy, their disease process, all these different factors. So a lot of thought goes into what surgery I'm going to be doing before the surgery, during the surgery, post-operative care issues after the surgery, and it's not a automatic cookie cutter operation, even though it's all called an endoscopic sinus surgery. There's so many decisions that I'm making during my operation to make sure that I have a good long-term outcome.
All right, thank you, everybody. Well, this brings us to the end of the course. The 10th annual Seattle Otology Advanced Rhinology course is officially over. Thanks for your attention, guys and ladies. And love to see you back. March 2023 will be tentatively our next one. So again, safe travels home. If you have any questions, we're going to be hanging out for the next 10 minutes. There's some beverages over here to polish off. And thanks again.